I am delighted to introduce the next speaker, who is Moniek de Witte, and the title of her talk is Alpha-Beta CD19 depleted grafts and allogeneic HSCT combined to personalize immune intervention to optimize the GVHD relapse-free survival in adults with myelofibrosis and emboreros of immunity. Please, Moniek.
Thank you so much, Professor Locatelli, for the introduction, and Miltony for this wonderful symposium. And at least we will talk a little bit about alpha-beta depletion as well, and touch upon a different kind of disease, mainly the chronic myeloids for adults. So I hope you will hear something new. So I think I very much align with the two previous speakers that I think now we really aim for improving DRFS, not only for the non-malignant, but also for the malignant diseases. And in my opinion, that has to start with reducing complications. And I hope to show you now how also for adults at a considerable age, a myeloablative conditioning can be combined with ex vivo alpha-beta T-cell CD19 depletion and still result in promising GVHD. So I would like to start with our own single-center experience we have now. We have pioneered this for the last for the last 5 years. And what we do is we indeed give a myeloablative conditioning, so also to elderly patients. We still use busulfan. We combine it with early HCG to promote engraftment. And then we give the alpha-beta T CD19 depleted product. The immune suppression is typically short, 28 days, single-cell agent, and we give prophylactic DLI to enhance immune reconstitution. And this is still a modified DLI. And here is where we compared it to our retrospective cohort. So the interventional cohort is the lower graph, so in light gray, cohort depleted. And we compared it to recipients of matched donors. There we didn't, match-related donors, there we do not add HCG. And of unmatched donors, and there we added HCG to the graph. So these are T-cell replete allografts with cyclosporin and MMF. And what you maybe can appreciate, I'm not sure, can I? Does this work? Ah, yeah, we have a laser. What you can appreciate is that the incidence of acute grade 3 to 4, but especially of extensive chronic GVHD, is really low with the ex vivo depletion platform. And this translates into an improved GRFS. However, here the follow-up is still relatively short. So I am also very happy to present on Wednesday on the symposium, very last session, so please stay, the results of an EBMT retrospective analysis which we did. And there we compared CAMPET, the ex vivo graft engineering and the post-LOCI, and we also looked at clinical endpoints. And here's already some of the results we are going to show, and that is again, in alpha-beta T-cell depletion in blue, low rates of extensive chronic GVHD. And also here, these are the curves for GRFS. However, in the multivariate analysis, this was not significant. So, in our institution, we have shown that this is a solid platform, but can you optimize it for specific disease types? Because one disease to another maybe reserve a different tailoring. And today I'm going to talk about myelofibrosis and about inborn errors of immunity. And for those who are maybe not familiar with the typical patients with myelofibrosis, they are in general of higher age. They have constitutional symptoms, so the risk of GVHD tends to be higher. And they also have a fibrotic bone marrow, frequently splenomegaly, which can maybe compromise engraftment and graft function. And this is also demonstrated by these data of an EBMT survey published 2 years ago, a cohort until 2018. And you can see that especially the non-relapse mortality is high, 1 out of 3 patients. And the incidence of chronic GVHD, and the extensive chronic GVHD is 23%. And this is a mixed bag of conditioning regimens, graft manipulation strategies, etc. And they also show that older age, a non-sibling donor, CMV seropositivity, and a poor compromised Karnofsky score associated with worse outcomes. And obviously, those are parameters which are hard to influence. So when we had the alpha-beta T-cell CD19 depletion platform in our center, we figured out after the first couple of patients with MF that we needed some extra measurements. And so what we did, based on the data of the Hamburg group, is we added ruxolitinib, so a JAK inhibitor, to the immune prophylaxis regimen, only for starting at day -5 until day 14, so really short term. And later on, we were able to do MRD monitoring and implement preemptive DLI. And this is a busy slide, and I think it's difficult to see, but it's a single center analysis. So with ruxolitinib, it's 28 patients. And first of all, the age is, so a median age of above 62. Most patients were already on a JAK inhibition prior to SCT. About half of the patients had an enlarged spleen. And also in the ruxolitinib plus group, we added CD19 depletion to the platform. And what you can perhaps already appreciate from this slide, so in the solid line, that is the alpha-beta T-cell depletion with the ruxolitinib as immune prophylaxis. The non-relapse mortality reduced dramatically. And this is some preliminary data where we try to understand why is a single agent short-term during the inflammation of the conditioning helping, or what is it adding? And here we did a proteomic analysis where you can see this is at week 3 after conditioning, and blue means it's lower than in healthy controls, that all the inflammatory pathways are actually still suppressed. Whereas this is an AML cohort, so same platform, no ruxolitinib, and there you can see the inflammatory proteins going up, and we are actually analyzing this more in detail. And secondly, we also, of course, looked at immune reconstitution. What you can maybe appreciate is that the NK cells, they stay normalized throughout immune recovery. That's what you expect, of course, by your type of graft engineering. Same holds true for the gamma delta T cells. The depletion of the B cells in the beginning, what you expect, maybe also helps in preventing chronic GVHD. That's not something we can say by certainty, but comparing to other centers, this may be part of the explanation. And also you can see the CD8 cells are coming up after a year and the CD4 cells a little bit lower. So having reduced the GVHD, we then were considering how to manage relapse. And for that, we implemented MRD measurements by doing a digital droplet PCR for the driver mutation. And this is just a summary of what happened to these patients. So here are patients where we did not have the MRD yet in place, but you can still see that when they have a relapse, they respond to DLI. So the numbers refer to a DLI. And here there is preemptive DLI installed. And also here you can see that they recover and generally without GVHD. So to summarize, we were able to tailor our platform to myelofibrosis. And I think the numbers here compare favorable. Of course, it's single center, small numbers to what is published in bigger retrospective data sets. And you can see here the curve that the GRFS for this difficult to transplant patient group really improves. Now, before I go to the inborn errors of immunity, I would also consider that maybe MDS patients should be considered the same way as patients with MF, because again, this is a publication of the EBMT, and also here ATG and post-SI, that's of course more implemented, is compared. And you can see that the non-relapse mortality for the patients with MDS is around 25 to 31%, so also still very, quite considerable. And I would say that maybe with the approach of adding additional immune suppression, we could also do something beneficial for these patients. And we are now preparing a clinical trial because ruxolitinib we cannot give, is not reimbursed for MDS patients, but we are preparing a clinical trial to also do our platform in patients with MDS. So this is about malignant diseases we see relatively often, so the chronic myeloid diseases. Then a few data on inborn errors of immunity. Of course, there I have to look at the pediatric physicians. They see it much more often, but it's now more commonly diagnosed in adults as well. And this is where they compare allo-SCT without allo-SCT in an adult cohort. And this is, I think, also the silver plate the first speaker was alluding to. We should really try to prevent this drop in the curve. And if you see what they die of, or which problems they are facing, is generally GVHD. And actually only 1 out of, so this is adults, only 20% of patients go through the whole transplantation platforms without any complications. And for pediatric patients, post-allocy is already compared to ex vivo graft engineering. And I think both approaches look very promising. And we also saw it 2 presentations ago. Well, that was, of course, about hemoglobinopathies, but still. And what we found is, so we use a little bit a different conditioning regimen. And we learned that for this specific type of diseases, you have to really personalize your post-transplant immunosuppression. And just to see what type of patients we are transplanting, it is very heterogeneous. And I think people who treat patients with inborn error of immunities recognize that. And what we started is that some people are on immunosuppressive agents prior to SCT, and we decided to give this to keep continuing this. What I think also is very nice about the platform is that you can use preemptive DLI. If you see a drop in chimerism, either early or later, you can restore the chimerism. And also here, we see relatively favorable immune reconstitution. And these are the data for adults we observed in our clinic, but I think this forest plot says more, or this that you can here see by patients that after the treatment, there is an intense hospitalization in the beginning, but after that they are free. They actually get their life back, so they are free of medication, no GVHD, no rehospitalizations. So yeah, also now adults are referred more for an allo-SCT. And that brings me to my last slide. So improving DRFS starts with improving engraftment and GVHD. And I hope that I've shown you that also for adults, also at a higher age, you can give myeloablative conditioning. And if you then give an ex vivo engineered product, the incidence of GVHD is really promising. And once you've established that throughout the first 3 months, you can personalize your platform to really tailor your SCT. And that brings me to my acknowledgement slide. As always, you cannot do that without a big team. And I like everybody who's on this slide. And give the word back to you, Professor Locatelli.